You're allowed 40 minutes. Because I signed in a little early, we're already about 5 minutes in. So we're going to be around 35 minutes. And we're in prime Netflix hours anyway. And so we don't want to get cut off, because I once gave a talk and then all of a sudden it was like, boom, we're done. And that was the end of it. So a couple of house cleaning things. I'm going to ask that you put yourselves on mute as best as you can. So hopefully you can do that. That way you have a clear ability to listen to the talk. And we're not going to get hearing some background stuff like toilets flushing and some music or the neighbor's dog or things like that, because that's what goes on in these Zoom worlds. So I'm going to start off. I'm going to introduce myself. I am Mark Greenstein. I'm a urologist with Advanced Urology in Sandy Springs. I've been in practice 18 years, and about, I don't know, around 2007, 2008, 2009, I honestly don't remember anymore, I got into this world of pelvic pain disorders because there were many patients coming to our office. This was when I was practicing in New Jersey, with pelvic pain, and no one knew what to do with them. And it was always, here's your antibiotic, here's your pain medicine, here's your antibiotic, here's your pain medicine. And I realized that that's just not right. And what I did is I was able to start learning from patients, learning from other doctors, learning from physical therapists, that there's a whole world of treating pelvic pain disorders that a urologist or a urogynecologist or even a gynecologist can get into. And as life has gone on, it's really taken off. And, where I used to practice, there was maybe 2 pelvic floor physical therapists. There was not a single rehab person that was available to help that. In Atlanta, I mean, there is a wealth of pelvic floor physical therapists, and now we have Dr. Yogita Tailor. And so Dr. Yogita Tailor recently opened up an office with pelvic rehabilitation medicine. Are you in Buckhead or are you in downtown? What are you considered?
We're in Buckhead.
Buckhead. And
yes.
I've asked her to give us a talk today about the role of pelvic muscle injections for pelvic pain. And so I'm going to introduce Yogita and let her take the show here. I'm going to be just the guy who is going to change the slides. We're going to go over some stuff, and then we're going to do a couple of case reports. And then if there's the ability, open up the chat for some questions. So Yogita, you are on. And Yogita, please introduce yourself, your background, what you do, and all that fun stuff.
Sure. Thank you, Mark, for coordinating this and kind of organizing. And it's been wonderful kind of collaborating with you over the last several months as well. So a little bit about myself. So I'm a physiatrist. That is a physical medicine rehabilitation doctor. So I am trained in nerves, muscles, joints, and training from head to toe in this arena. And during my training, I was introduced to the pelvic floor briefly. And when I started practice in 2013, I saw that there's a huge need for, addressing chronic pelvic pain on a global standpoint. So prior to my role at pelvic rehabilitation medicine, I was at Emory, where I did do some women's health and women's pelvic floor dysfunction. I really wanted to focus my energy and time on this, as this chronic pelvic pain is such an underserved area. And I, as a physiatrist, again, my role in addressing the nerves, the muscles, the joints, which the pelvis definitely encompasses. It's been a very rewarding role. So our practice, Pelvic Rehabilitation Medicine, is a national practice, original office in Manhattan. And with the concept of everything that we do, I truly felt that there was a huge need in Atlanta. And so we were able to open up our practice September of 2020, where all I do all day, every day is see patients with chronic pelvic pain. And, in the unfortunate scheme of things, some of the patients I see have been dealing with their pain conditions for months, years, and even decades. And Oftentimes it's the pelvic floor that's not necessarily have been considered. You know, patients can go from different providers getting maybe organ systems assessed. And again, Mark kind of alluded, some patients go from antibiotics to pain meds to antibiotics and things like that. But our role is really a collaborative role in terms of addressing the pelvic pain with combination of physical therapy, medications, and things of that nature. And I know today's webinar is primarily, we're going to talk more so on our injections and what the purpose of the injections and kind of the science behind them. We won't get into the nitty gritties of the science, but kind of what the grand scheme of what we're doing. We'll go ahead and get started.
Not sure where to put this guy, but okay.
So we can go ahead and move to the next slide. All right, so again, just a brief definition of what chronic pelvic pain is. And almost 100% of the patients that I see, their pain comes from more than one place. You know, it's very multifaceted. And the pelvis, as mentioned before, has a lot of things going on. We have for our females, we have our GYN organs. For our males, also our GU structures, you know, bladder, prostate, all of that. But then there's also the spine that's in very close proximity, providing the innervation into that area. The hips are right there. External organs are right there. And, you know, we're really localized to lower abdominal area, pelvis, buttocks, and the low back. When we're defining chronic pelvic pain, it's usually greater than 6 months, can be kind of a continuous ongoing thing that people feel, or it can be something more intermittent, situational. Of course, pain with sitting, pain with exercise. Usually what we're dealing with is not necessarily associated with pregnancy or malignancy, just a cancer. And the big thing that we're addressing is how much this pain is affecting our quality of life and function. And again, as a physiatrist, that's a big thing that I deal with, is improving quality of life and function. So we can go ahead to the next slide. So again, when you think about the pelvis and pelvic pain, automatically a physiatrist is not someone we would think about. And so it's very common that I'm not the first stop when patients come to me. But again, with kind of things of this nature, kind of doing more advocacy, I don't want our patients to be waiting too long to be seeing someone who kind of devotes their time to pelvic pain. So when we look at the pelvis, you can see there's a connection of muscles, and it's not just one muscle doing this. It's a connection of muscles that work together. The muscles, with combination of our abdominal muscles and our back muscles, make up our core. So when people talk about working out their core, please don't forget your pelvic floor muscles. They're the floor of the core and really the support of everything. And so they're part of holding us upright. They're part of holding our organs, including, you know, babies when patients are pregnant, and your bowel, your bladder, your intestines, all of that. So, and they also serve as part of continence. So the coordination of these muscles allow for us to hold our urine and stool when we want to, and also relax so that we can go to the bathroom when we want to. And then there's the nerves, and a big portion of what I deal with includes the nerves that start in the lower back and then travel into the pelvis. You'll hear about the pudendal nerve a lot, because that's probably the most commonly affected nerve in the pelvis, because it's one of the biggest nerves, and it has multiple branches that come off of it, going into the rectal area, going into the penile testicle area, going into the vulvar vaginal area. So the pudendal nerve is a very important nerve that we deal with. And then the joints, again, there's multiple joints in the pelvic area, including the sacrum. The SI joint is something, a dysfunction that we see very often. We have our hip joints. And when we have hip pain, it's often groin pain, like pain in the groin area. So again, lots of connection there. And then when there's dysfunction, whether it's with the bladder or with the uterus or the bowel, there's a lot of crosstalk, especially when there's a lot of irritation that's been going on for a long time. These nerves within get irritated and kind of talk to each other and kind of each other as well. So let's move on to the next slide. And when I treat my patients, you know, we spend a lot of time getting to know the pain, kind of the history, everything that's been going on, and everything kind of related to their pain. And it's very often that the central nervous system, which includes, you know, from our head to toe, and then the peripheral nerves, which is the more localized nerves, are affected. And these nerves have kind of gotten used to feeling this pain, and the threshold for feeling the pain has come down. So part of the goal for our injection series is to retrain our nervous system, central as well as peripheral, and decrease the inflammation around the nerve. So there's lots of inflammatory markers. Again, I'm going to throw out some words like substance P and histamines and things like that. There's a lot of inflammatory, it's almost like a soup around these nerves and muscles that's causing a lot of irritation. And then there's muscle tension. So these, when we get irritated, when our body's trying to compensate and protect ourselves, our muscles kind of squeeze and get tense like this. And oftentimes when these muscles are constantly in this position, they get stuck in this position. And that's part of kind of the dysfunction that we're treating, kind of minimizing that tension, getting those nerves and muscles kind of back into their normal place. Because if you think about a muscle like this that's really tight, the nerve is inside of there, and that nerve is constantly being squeezed and irritated. And then we're also working on lengthening and strengthening that pelvic musculature. And this is, again, in combination with, you know, the great work our pelvic floor PTs do, as well as medications and things of that nature. So one important thing is never to think that these injections are magic. These injections work the best when they're done in collaboration with working with my urology colleagues, GYN colleagues, pelvic floor physical therapists, and occupational therapists as well, our cognitive behavioral therapists as well, because again, when you're feeling pain for a long time, it's a mind and body issue that we're dealing with. All right, next slide. All right, so kind of a treatment algorithm for the chronic pelvic pain, and everyone's situation is very individualized. You know, everyone's situation is different, and things to think about is how long have these patients been dealing with this pain, how much is it affecting quality of life and function, and what have they tried for their treatment aspect. Important parts, like I mentioned before, is pelvic floor physical therapy. That manual treatment is definitely key. And for some patients, that can be a big place to kind of get them over that hump. Oftentimes, I'll also prescribe suppositories for these patients, again, to kind of help relax these muscles and kind of help with that retraining process. And ideally, we'd like for this to be tried for 4 to 6 weeks. And again, that 4 to 6 weeks is not necessarily a hard and tried rule. We have patients that come in that have been in therapy for longer or less, or have never been introduced to therapy. So everyone's situation is different, but things to also think about, you know, the therapist is going to work on posture, gait, the myofascial release, mobilization of the viscera, and the viscera is kind of those internal structures. And so if they're in a tight position, it's important to kind of help open that space up. There's different modalities that can be used, like ultrasound, TENS units, and then thinking about other things, like if there's pain with sitting, like getting a cushion, an SI joint belt, looking at kind of their workstation and seeing, is this ergonomically appropriate? Looking at lifestyle modifications, you know, how much stress are we dealing with? Like I said, when we get stressed, we clench, and kind of being mindful of our habits, our nutrition. There's certain foods that can be irritating, especially to the bladder, in terms of conditions like interstitial cystitis, as well as endometriosis. Also, exercise history, you know, like we're trained to do more and more, but sometimes that pelvic floor is saying, hold on, like please, please get off that bicycle because my nerves are not happy. And also looking at other alternative therapies, acupuncture, yoga, craniosacral treatment as a form of treatment as well. And then also looking at medications. So medication-wise, I do tend to avoid opioid treatment. There's no data to support that opioids will help chronic pelvic pain at all. Yes. And the medications I would consider more to help calm down that nervous system. We have membrane stabilizers like gabapentin and Lyrica, and then also kind of antidepressants as well that also work on the nerves and muscles as well, such as amitriptyline and Cymbalta. And again, everyone's situation is different, where some people may benefit from one over the other, or, you know, it's a decision that we make together. And I always tell my patients, I'm not here to throw medications at you. We're here to work together to provide you the most optimal care. And again, we're here to talk about injections. So let's talk about trigger point injections and peripheral nerve blocks. So these injections are meant to target two different areas. So the trigger points are more for the muscle, right? So trigger points are meant to help calm down muscle tension, and then the peripheral nerve blocks are meant to help calm down the nerves. And in our injection protocol, we kind of target both at the same time. So we can go on to the next slide. Actually, before we talk about this, so we address both because the question always is what was that initial irritation? And oftentimes there's some kind of underlying pathology. You know, it can be related urologically, it could be a bladder problem, it can be a GYN issue like endometriosis, it can be an orthopedic issue like, you know, labral issues of the hip. But when it comes to the nerve and muscle, oftentimes they kind of work hand in hand. It's hard to decipher what came first. It's like the chicken or the egg, because when the nerve gets irritated, it causes the muscle to get into tension. And when the muscle is in tension, that nerve is getting irritated. So when we're just treating both, we're not necessarily treating the pain because both of them are involved. So in our injection series, we want to target both the nerve and the muscle. And when we do these injections, there's different medications that are options. Oftentimes, when we do our injections, they're done in a series because one injection is difficult to break that cycle. We do a series of 6 injections, typically 3 on each side, and we alternate left, right over a period of 6 weeks. And when I start the injection series, typically the first 2, the first on the left, first on the right, will have steroids because we want to calm down that inflammation around that nerve. But lidocaine also has very powerful properties as well. So lidocaine you may be used to with a dentist, you're used to numb the area, but when you are kind of when the nerve is repeatedly exposed to that lidocaine, that also helps to calm down that irritation. And essentially what we're doing is kind of shutting down that pain signal, and when that nerve kind of restarts, we want it to be firing a little bit more normally. And so with our subsequent injections, we have lidocaine embedded in there so that we're getting our nerves in a better environment and calm down. And again, we're also working on opening up that space around that nerve. So it's what we call a hydrodissection. We're opening up that space so that muscle is not constantly squishing on that nerve. And we're breaking down any tension like fascial tension or adhesions in there that could be also contributing to this pain. So next slide, please. Okay, and our injections, again, specifically are ultrasound guided, so we see exactly where we're going. And our injections are external. So when you think about pelvic injections, it sounds kind of almost cringeworthy to some, but think about it like this. We're going into the muscle, we're going through the butt cheek. We're not going into the vagina or rectum or through the penis. We're going through the butt cheek, and we use our ultrasound to see exactly where we're going. And we target very specific muscles of the levator ani. And when we go there, so we're targeting around the nerve first and breaking up around that nerve. And as I'm coming out, I do an injection, a trigger point injection to break down any tension. And when we do our injections in a series, what I often see is those first couple there's a lot of twitching and spasm. And as we kind of go through towards the end, the muscles are more calmed down. So we do see visually and kind of contextually improvements as well. Like I said, our injections are in a series. I wish one injection would knock it out, but again, that's not how our body works. We do our injections in a series once a week for 6 weeks. And the injections typically are tailored towards where the patient's pain is and what their dysfunction is and what nerves and muscles we need to target. But again, that pudendal nerve tends to be playing a huge role. So we're addressing both the muscle pain as well as the nerve inflammation. Next slide, please. And again, this is kind of an overview of what inside the pelvic floor is. So this is the female pudendal nerve. I don't think I have access to the arrow. I don't think you can see that, right? I think Mark does. So right there, yep. And it's on both sides. The diagram doesn't necessarily show it on both sides to make it cleaner. But that, if you see all those branches that are coming out of there, it's going into that rectal area, vaginal area, clitoral area. It really targeted to where, can affect how we sit, how we, bowel movements, urinary, intercourse, all of that tends to be highly affected when that pudendal nerve is irritated. Next slide. And a similar slide right in here. So this is a male anatomy, and I don't know why they're flipped upside down, but that pudendal nerve is right in there. And again, those branches, especially that dorsal branch of the penis, can go all the way to that tip of the penis. So for men with like tip of the penis pain, and that kind of coordinates with clitoral pain in females. And these nerves and muscles, they're very complex, and again, kind of sitting within the muscles of that pelvic floor in there. Okay, so this is just kind of an example of what we can potentially see in our injection. So that first slide is before the needle's inserted, where you see the target that says ischial tuberosity. It kind of looks like a little snowy peak, and right medial to that is Alcock's canal, where the pudendal nerve lies. And that second picture there is where you can see that needle coming in with space forming around that pudendal nerve where that circle is. And in this slide, there's injection of A2M, which is kind of more of a regenerative medicine type of injection. I don't do this here. Our office in New York City does, but it's kind of a similar concept as to what I'm doing in terms of ultrasound. You can see that fluid expanding. Again, we're opening up that space. We're breaking down fascial tension. We're also helping to lengthen that muscle as well. And then that last slide is kind of once the procedure is complete. And I often get asked, on week to week, can you see that nerve and muscles opened up a little bit more? That medicine resorbs into the tissue. So it's not that I can see from week to week, but I can definitely feel from week to week a difference when I'm doing these injections. And I've also had feedback from our physical therapists that say, hey, I can feel where you went. And going back to physical therapy, when we're doing these injections, I want our patients to be seeing physical therapy at the same time, because the changes that we make can augment what the physical therapist can do, and the changes that the physical therapist makes can augment what we do. So again, we're looking for long-lasting relief. Our injections are not meant to be, come back every 3 months for this. It's meant to really retrain your pelvis and get your pelvis back to normal. Next slide. I think, yes, so this is a video. Hopefully we can play the video of showing
Nice.
an injection actually happening.
So where's your ultrasound probe, Yogita? Like, where is it? Is it on the tummy? Is it in the tush? Is it?
It's on the buttock. Yeah. So it's kind of right next to where I'll be going. We have our patients, whether men or women, kind of in that they're laying back,
Lithotomy.
legs spread apart, and we're going in there. And again, what does this feel like? Many patients say it kind of feels like, you know, a flu shot. It's into the muscle, and there's no anesthetizing beforehand. You know, take a anti-inflammatory beforehand, but it's about a 15-minute procedure, and then you sit on ice for about 10 minutes, and then you can go about your day. And ideally, going to your PT the same day or within a few days is ideal. So here you can see.
Just to go back, and let me interrupt for a split second. So up here, this is your ischial tuberosity.
Yes.
Right, and then this is like where the nerve is exiting near the ischial tuberosity and the surrounding muscles.
Yeah, and that line right there is that needle.
And then this is the needle. Nice.
All righty.
Uh-oh, running out of time.
All right, next slide. All right, so other nerves we target, like, so that one was the pudendal nerve. Ilioinguinal is another one that, ilioinguinal is kind of on the lower abdominal area, especially for patients that may have that pubic type pain. And again, on that picture, you can see kind of where the ultrasound probe is, and where we're targeting is that ilioinguinal nerve, which is right in between the transverse abdominis muscle and the internal oblique muscle. And the next slide will really show a great video of that space opening up when we do our injection. So if you look kind of at the top half, there we go. So this one's a nice dramatic opening up.
Nice. So this is the fluid going in here.
Yep.
This is the nerve. This is the nerve here, right?
Yes, right in the middle. Yep.
Yeah.
And then below is the transverse abdominis muscle, and above is the internal oblique.
Nice. Looks like a prostate biopsy when I do it, because we're putting fluid in right into the back of the prostate, and you watch it go inside. So the black is fluid right there.
Yes. All right. So again, we're trying to target big parts of what causes chronic pain. So there's muscle spasm, decreased blood flow because of the tight space. There's inflammation around the nerves and the inflammatory mediators, nerve irritation, weakness, compensation from our bodies. And that central sensitization is, you know, we're talking about the pelvis, but this affects people from head to toe. It affects their mood. It affects relationships. It affects their ability to go to work. It's kind of life encompassing. And our goal is to get patients in a better place, get that quality of life back, get that function in a better place. And if we go on to the next slide, you know, this is a big part of having that healthy lifestyle. Again, targeting the mental health, the exercise, you know, wellness, consciousness. Again, we're talking about the whole person and how much the pelvic pain can affect everything. And so this is a big part of getting well. But like I said, nothing is magic. Injections are not magic. It's a part. We really got to include all of our parts to this, and that's what makes kind of chronic pelvic pain a little bit complex. But when we treat it well, it's very rewarding. And so I'm grateful to be able to do what I do. All right.
Yogita, that was awesome. And what I'm going to do, because we're on a little bit of a time crunch here, I'm just going to go through two little case reports. They're made up, but they're kind of common to Yogita and I.
Yes.
So we'll say that this is and then we have like I said, our time crunch. So we have a 56-year-old female, pelvic pain with intercourse, which is called dyspareunia, urinary symptoms of urgency, frequency. On exam, she has trigger points. So just like when you touch someone's back, they're like, "Ooh, I feel that." Well, people have them in their pelvis. Minovaginal atrophy, in other words, a little bit of menopause. She gave us a urine sample. It was normal. She was referred to pelvic floor physical therapy and a series of pelvic floor injections by the great Yogita Tailor. And her pelvic floor improves, but she still has urgency and frequency. And then she starts saying it hurts to hold in her bladder. I'm just going to go right to the answer. I got a hold of this patient. She has I did a cystoscopy under anesthesia, which is the only way to do cystoscopy with these pelvic floor patients. Because if you ever want to ruin someone's day, take a pelvic pain patient and put a camera in their bladder awake. And it shows classic interstitial cystitis. And so Yogita actually had a patient and I, similar, just like this, that we were able to collaborate with. I look at this as, this is a patient that's had interstitial cystitis for who knows how long, could be 10 years, 20 years, and it just threw off the entire pelvis. And the nerves were irritated. She was not good in here. Her nerves were messy. Sex life was thrown off. Yogita was able to work on the muscles. I was able to work on the bladder. And we now have a very happy patient, I mean, who is almost symptom-free at this point. I saw her about a month or two ago. Yogita, any comments on this?
No, I mean, this is a perfect case where, again, she was one that hesitated a lot to address this. You know, she was dealing with it and she wasn't comfortable. But at the same time, you know, life was kind of getting in the way. And she finally decided, okay, let's see this. And oftentimes what we see is when these patients come in, there's a lot going on. Everything feels like it's all over the place and so generalized. And as they get better and better and better, we can start kind of peeling away at things. And we treated her kind of very generally based on her symptoms. She did great with physical therapy. And then when she came for her follow-up, she's like, I feel great. But again, like Mark mentioned, there's these very specific bladder symptoms that she probably wasn't able to describe before.
Right.
Now she was able to kind of really localize this. And when she went to Mark, got her treatment there done, you know, she was like, you know, I can't imagine everything that I was going through. And again, this, even though she's feeling great now, it's not the end for her. Like, there's still a lot of maintenance. It's about kind of keeping up with the stress management, exercise, breathing techniques, making sure she's eating the right foods, because otherwise she can go back into a flare, and we want to prevent that. And we want to give her the tools so she can treat herself and be independent from us, from injections, from PT, from installations, and all of that. Yeah,
and also add on, some of these patients need a psychiatrist. Some of these patients need a psychologist. You know, there's two different things there. This is a condition where it takes a village. It takes a team approach to help them. Just going to move on here. So this is my favorite one. 45-year-old male diagnosed with chronic prostatitis, 4 rounds of antibiotics with minimal improvement. Prostate is normal, ultrasound normal, cultures are all normal. He has numerous trigger points on exam. Prostate and ultrasound and bladder ultrasound normal. So in other words, when I see these people, I'm going to make sure there's no stone. I'm going to ultrasound their prostate to make sure there's no prostate stones. I prescribed him Valium, baclofen suppositories, and he's like, holy cow, we're onto something. I did a cystoscopy on him. Bladder's completely normal. This guy does not have prostatitis, and I send him to Yogita. And so, Yogita, what would you, we have 2 minutes. Well, it's like Jeopardy. What would you do with this individual?
I mean, so I do see this a lot where these men say, okay, I was diagnosed with prostatitis maybe 20 years ago, cleared up, and then it came back afterwards. And again, the question is, what was that initial instigator? Maybe it was an infection, cleared up, but those muscles and nerves were there, and they took the brunt of this inflammation and pain, and they get ignored. And so they're response to the suppository shows that, yes, there is a nerve and muscle issue. And again, depending on what path they need, we can do injections into the specific areas of their pain. Again, oftentimes that pudendal nerve is very much involved. And again, getting their pain under control, and again, making sure there's not anything else underlying going on. You know, if there's hernias or back issues or hip issues, that also can contribute as well.
Right. Exactly right. So, you know, in this ideal situation, this patient would eventually end up in pelvic floor physical therapy. You know, depending on how long this has been going on, they may even see a psychologist, things like that. We'll work with their primary care doctor. Unfortunately, because of the world of Zoom I live in, we're going to have to wrap this up. Unfortunately, there's not going to be any questions. You can always write to us at the practice, mgreenstein@advancedurology.com.